There are various ways AFOs can be utilized. They can limit motion of a joint. They can restore motion of a joint. They can decrease load on soft tissue structures, most specifically the posterior tibial tendon. And they can offload the plantar surface of the foot when we treat Charcot-arthropathy and neuropathic ulcerations. To understand how AFOs work, we really have to go back and look at the biomechanics of AFOs. I wrote this article up 4 years ago, and I will tell you it was the most challenging biomechanical piece I've ever written, because it goes far above just looking at the foot, at the subtalar joint, and the ankle joint. There are 4 basic mechanisms that ankle-foot orthoses work. These 4 mechanisms are complicated, and I'm going to just share 2 of them with you. The first is simply restricting rotational motion about a joint, and most particular, the ankle joint. These braces require 3 points of fixation, and they basically try to push a body segment into a preferred position of alignment. They are the typical posterior shell ankle-foot orthosis that really was the predecessor for the more complicated devices that I'm going to share with you in a few minutes. They were originally designed to treat polio victims in the early 60s, mostly children who had a drop foot condition. They're designed to maintain dorsiflexion of the ankle when there's muscular weakness from either neurologic damage or skeletal muscle damage. We, as podiatric physicians, commonly treat patients with drop foot, whether they've had a stroke, Charcot-Marie tooth, multiple sclerosis, injury to the common peroneal nerve, either from trauma or surgery, and we occasionally see traumatic brain injured patients. When we treat drop foot conditions, it's very complicated and it's very challenging. But there are some simple parameters I could share with you, and that is you have to watch the patient walk and you have to look at their knee. And if they have a stable knee, you can use an articulated AFO. But if they have an unstable knee, you must use a solid shell AFO. That is a very simple rule, and it works in almost every case. This is a patient with an unstable knee. It's an extension deformity, a recurvatum. This patient's knee can be restored in alignment with an AFO. This is a flexion deformity of the knee where there's weakness of the quadriceps muscle. Sometimes you'll see that after a stroke. Sometimes you'll see it with muscular dystrophy or multiple sclerosis. In either case, a solid AFO is needed to straighten the tibia, restore alignment of the knee by restoring alignment of the ankle. But when you do use a solid AFO, you have negative effects. It increases flexion moment to the knee. It increases dorsiflexion moment to the midfoot, and it reduces balance. All 3 of these are not desirable conditions, particularly for elderly patients. If we had our choice, we would use an articulated AFO that has a dynamic hinge that would allow dorsiflexion of the foot during swing phase, but allow free motion of the ankle during the stance phase of gait. We developed this brace about 10 years ago that has been extremely popular in the United States for drop foot conditions. It's not for every patient. 3 rules must be applied. The patient must have a stable knee, they must have available dorsiflexion at their ankle joint, and they cannot have spasticity or contracture. Fortunately, it is found commonly that most patients with a stroke meet this criteria and can be treated with this brace. I showed you earlier this gentleman who wasn't a stroke patient, who basically had a nerve injury, but this is a flaccid drop foot with a stable knee where he can be placed into a dynamic hinged AFO. And as I showed you before, the results are quite dramatic. So we're going to line this up here. This is another patient who has a common peroneal nerve injury. You'll see that he has otherwise a very normal gait pattern, but a flaccid drop foot. He has a stable knee. He has no spasticity, no contracture. In this case, we would want to use a dynamic hinged ankle-foot orthosis. And as you can see, when we apply a device like that, the results are dramatic. This restores an almost normal gait to a patient who otherwise is fairly significantly impaired. This is a neuromuscular case of a child. We don't see this very often. This is a post-polio patient from the Philippines who moved to California, he has a flaccid drop foot. You can see the dramatic improvement of control with a relatively simple brace that a younger patient doesn't mind wearing because cosmetically it doesn't look as imposing as the more standard ankle-foot orthoses. But the most challenging condition we in the United States use ankle-foot orthoses is this, the adult acquired flat foot. A fascinating biomechanical challenge because it is the result of ligamentous disruption of the ankle and hindfoot, which leads to extreme, as we call it, translational deformity of the lower extremity and the foot itself. When we want to correct translational motion at a joint, which occurs when there's loss of ligaments, we have to make a brace much more sophisticated. It has 4 points of fixation. It has to be rigid, and it has to have straps and pads that can be applied tightly to the surface of the skin. They can be tightened by the patient to control rotational movement of the tibia or the femur, wherever else. So to restore alignment in this complicated deformity, you must have straps and pads that are fixed tightly to the skin and that can be lifted and adjusted to correct 3 planes of deformity. This is the same concept that's used in modern day knee braces, particularly in athletes who have had anterior cruciate ligament tears. These are very sophisticated braces, but they follow the same principle. Straps and pads that are adjusted and tightened against the skin to control rotation of the body segment. These braces in the United States cost about $2,000. It is commonly seen that most Division I football teams, all of the linemen wear these braces prophylactically to prevent catastrophic ACL injury. What we're trying to control in the adult acquired flat foot is internal and external rotation of the tibia. To do that, we must grip the lower leg tightly, tighten the strap, and control rotation. The way we designed this brace was first of all following the root principle of casting for custom functional foot orthoses. We believe strongly that you must cast the patient off weight bearing. You must place the subtalar joint in neutral, you must lock the mid-tarsal joint, and you preserve the natural contours of the foot at the heel pad, the medial longitudinal arch, and the transverse arch all across the metatarsals. We believe it's important to capture forefoot to rear foot deformities, such as a forefoot varus in the right hand cast or a forefoot valgus in the left hand cast, and we believe it's important to intrinsically balance the cast and correct the deformity. These principles are followed in lower extremity foot orthoses, but also today in our ankle foot orthoses. We can incorporate additional measures such as the Kirby medial heel skive, very popular in the United States to impart an inversion moment to the subtalar joint axis to control excessive pronation. By extending the brace up against the medial malleolus, we have one more point of control, and that's adduction of the tibia. That's medial displacement of the tibia and the talus, which is really closed kinetic chain pronation of the mid-tarsal joint. So we have a brace that contours to the foot like a foot orthoses, and it has limb uprights to apply pressure against the malleoli and grip the lower leg to control rotation. So we take a patient like this, where it's a complex triplane deformity, and we apply those principles. We want to restore alignment of the tibia over the hindfoot, and it's very important that these patients be placed in appropriate footwear or the brace itself will fail. And this many times is challenging, and I think it would be very challenging here in Europe, as I've seen the fashion that women wear in Europe, even more so than in the United States, and to convince them to wear shoes like this, I admit, might be a challenge. We tested this brace at the University of Massachusetts. Chris McLean, who's a PhD, who studied under Joe Hamill. We've studied the rotational motion of a patient with posterior tibial tendon dysfunction, and we found that not only did we control calcaneal eversion velocity, but we significantly controlled the amount of eversion, the magnitude of hindfoot eversion. And then in the transverse plane, just as we theorized, we did significantly reduce transverse plane rotation of the tibia. Specifically, we controlled excessive internal rotation of the tibia, which is seen in the adult-acquired flat foot. You can see this control over the transverse plane significantly during the swing phase of gait, which is something that a foot orthoses has no capability of doing. Controlling the foot in swing phase is critical in controlling stage 2, stage 3 adult-acquired flat foot.